Hello and welcome everyone. Today we'll be discussing about pulmonary hypertension, from pathophysiology to the diagnosis and the new cutting edge management that is available. Pulmonary hypertension is a group of disease where the blood pressure in the lung arteries is abnormally high. The clinical features of this is breathlessness, tiredness during exercise, swelling, and signs of right heart failure. The main problem is that small arteries in the lungs become thickened and narrowed. That is, they have vasculopathy, making it harder for the blood to flow through them. It leads to shortness of breath, exercise intolerance, and features of right ventricular failure. And if left untreated, it can lead to fatality. There have been some recent changes in the diagnosis criteria. Previously, pulmonary hypertension was diagnosed when the mean pulmonary artery pressure was over 25. Now the diagnosis has been lowered to more than 20 millimeters of mercury and pulmonary vascular resistance more than 2 Woods unit. Early diagnosis and referral to the specialties is now a priority. So the key change in pulmonary artery hypertension, what happens inside the vessels, is the abnormal cell growth, that is proliferation, fibrotic and flexogenetic remodeling of the small arteries. This happens due to a complex genetic and molecular change. So these are the three types, that is pre-capillary, isolated post-capillary and combined pre and post-capillary. So these are the various numbers that you need to keep in mind while making a diagnosis. For pre-capillary, the mean pulmonary artery pressure has to be more than 20, the wedge pressure has to be less than 15, and the Woods unit has to be more than 2. This is for both pre and post capillary. If it is only post capillary, then the Woods unit can be less than 2. However, the other part remains the same. Obviously, because it is post capillary, the pulmonary wedge pressure is also elevated. So there have been many recent advances, and we'll go to more details of these new medications, new molecular targets, and the drugs that target the various pathways. We will go into the details of these various things. So there are various genetic and epigenetic factors which relate with pulmonary artery hypertension. There is mutation of the BMPR2 gene, which is very common in PAH patients. The change in the gene regulation, like methylation, demethylation, influence which gene is turned on and which is turned off. For example, mutation of the enzyme TET2 or an increase of DNMT3B affect the cell behavior, increasing the risk of pulmonary hypertension. Long non-coding RNAs like TYKRIL and the transcription factors like SOX17 and TWIST1 are new targets of therapy. So, what are these transcription factors? Mutation of the SOX17 can cause pulmonary artery hypertension and is often linked with heart and vessel malformations. Targeting proteins like the TWIST1 can help reduce the abnormal vessel changes. Regarding the BMPR2 and the right heart changes, the BMPR2 pathway abnormalities cause both vessel as well as right ventricular change. Drugs like 4-phenylbutyrate can rescue the BMPR2 function in animal studies. So there is a potential to repurpose these drugs for use in humans. BMP9 and BMP10 are proteins which are involved in vessel health. Changes in their levels is seen in some pulmonary hypertension patients, including those who have liver disease. Tyrosine kinase and the growth factor. Drugs targeting this pathway, that is ruloxitinib for the JAK2, can slow the vessel cell growth and improve the pulmonary hypertension in animal models. There is metabolic and oxidative stress. The pulmonary hypertension patients often increase the reactive oxygen species, which damages their blood vessels. Both harmful and protective reactive oxygen species are there depending on where and how much is being produced. Targeting enzymes like the NUDT1, which protects the DNA from the oxygen damage, can help in this particular condition. Mitochondrial dysfunction, that is the cell's powerhouse, is the feature in pulmonary hypertension. drugs that target the mitochondrial metabolism are being tested, like dichloroacetate. Impact of hypoxia and metabolism. Low oxygen, that is hypoxia, triggers changes in hypoxia inducible factors, that is HIFS. Drugs which inhibit these, like HIF2 alpha, can improve the pulmonary hypertension, but as of now these studies are all going on in animal models. Metabolic shift. The blood vessel cells in the pulmonary hypertension prefer using glucose over other fuels, leading to stiff and scarred arteries like in the cancer cells, and this is something which can be utilized as a target for drugs. You can have fibrosis and extracellular matrix formation. So there is excessive scarring, that is fibrosis, abnormal repair of the blood vessel walls, contributing to the pulmonary hypertension. Regarding chronic thromboembolic pulmonary hypertension, it involves blood clots which are small and large in number, causing inflammation and abnormal tissue repair. Proteins like NED9, SPARC, MMPs regulate these changes and may be a potential target for the drugs. Inflammation and immune cell. Inflammation and immune cell infiltration are important in pulmonary hypertension development. Currently, we have no such targeted therapy for this purpose. Environmental triggers can worsen and trigger hypertension, so they should be kept in mind. Studies are exploring how immune cells like the T cells and dendritic cells contribute to the vessel changes. Coming to the stem cell therapy, experimental approaches include using the stem cells to treat the severe cases. Benefits can come from substances released from these cells. New definition and lower threshold. So as we have already discussed, the pulmonary hypertension is now defined when the mean pulmonary artery pressure is more than 20. Before it was 25. Pulmonary vascular resistance more than 2 is also needed for the diagnosis. Both mean artery pressure and the pulmonary vascular resistance are important to avoid misdiagnosing normal physiological states like pregnancy, anemia, high output states as pulmonary hypertension. Clinical importance of PVR. PVR more than 2.2 Wood's unit is linked to higher death rates and heart failure admissions. In systemic sclerosis, when the mean pulmonary artery pressure is more than 20 and PVR is more than 2, it is linked with worse work distance, right ventricular dysfunction and decreased survival. Always interpret the hemodynamic data in clinical context. Pulmonary hypertension is a clinical diagnosis. It's just not a number that you are just putting in based on your calculations. So the new hemodynamic parameters are pulmonary capillary compliance, which measures how well the pulmonary artery can expand with each heartbeat. A low pulmonary artery compliance means worse right ventricular workload and higher mortality. In heart failure, higher CPA means lower risk of death and hospital admissions. Right ventricular pressure volume analysis, advanced technique to study the right ventricular function, often not available in most centers, but it shows how well the right ventricle and the pulmonary artery couple. If there is a poor coupling, then it will have worse outcomes. Some treatments have been used to improve the right ventricular contractility and measures for pulmonary vessel analysis. Pressure volume analysis. Regarding the diagnosis, the echocardiography and right heart catheterization can be done. Echo suggests that the pulmonary hypertension but right heart catheterization is needed for definitive diagnosis and proper classification. Repeat hemodynamic measurements can be needed if results are borderline and unclear. Timing of the right heart catheterization matters. For example, after diuretics, numbers can change, so interpret them well. Do right heart catheterization in patients with unexplained breathlessness or right ventricular dysfunction, or if the right ventricular pressure is more than 30 with no left heart disease. Now, exercise hemodynamics. In normal people, the mean pulmonary artery pressure and the wedge pressure rise with exercise. PVR slightly falls. Abnormal rise during exercise is pathologic and is linked with worse outcomes. Still unclear is how to treat the mild and exercise-linked pulmonary hypertension and improve their outcomes. So here what you see is the echo findings and the hemodynamic findings in pulmonary hypertension, which is given in a simplified manner. So in A, what you see is tricuspid regurgitant jet. Here you see the regurgitant jet the Doppler is measuring the velocity of the blood leaking backwards through the tricuspid valve. Here you can see the velocity is 3.75 millimeter per second, which is very high. Why this is important? Because it is used to estimate the systolic pulmonary artery pressure and there is a formula for this, and a high TVR suggests that there is very high pressure in the pulmonary arteries. The next is the short axis view, that is the D sign here you are seeing. Is a cross section through the ventricles. You can see the right ventricle is enlarged and it is pushing the septum into the left ventricle, making it look like a D. So this is a sign that the right ventricular volume and pressure is more. Next you have the TAPSE. It is a tricuspid annular plane systolic excursion. It is done in the M mode. It measures how much the tricuspid valve ring moves during each heartbeat. A TAPSE of 1 is seen over here, which is reduced. The normal is more than 1.6. A lower TAPSE means that the right ventricle function is compromised. Next, what you see is the pulmonary artery wedge pressure. You see the wedging has been done. Typical wedge dressing is seen. You see the typical venous dressing. Sorry, the atrial dressing. It shows a A wave and a V wave. And the important is that the pulmonary artery wedge pressure helps differentiate types of pulmonary hypertension. That is, you find out it is pre or post capillary based on this. If it is more than 15, it is post capillary. In pre capillary, it will be normal. Regarding the pulmonary artery pressure waveform, what you see is the pulmonary artery pressure with clear dicrotic notch, and this is important because it confirms the proper placement of the catheter. Wave morphology needs to identify the pressure changes and the abnormalities. You can use it to suspect pulmonary hypertension. If echo shows there is right ventricular dysfunction, these findings in overall everything in collaboration will help you find out what are the problems that the patient is having. Next, you have the next gen imaging, which is high resolution CT and special analysis, which can identify blood vessel loss. More vessel loss is higher mortality. CT can also show patients having hidden lung disease and which can predict prognosis. Patient with no lung disease and on CT have better survival because the hemodynamics can be managed better. Regarding the socioeconomic factors, minorities, that is Hispanics and those with lower socioeconomic status, have worse access to healthcare, higher hospitalization and worse survival rates. Rural patients again have higher mortality than urban patients. Methamphetamine use rises the risk of pulmonary artery hypertension by over 40%, and meth associated PH has worse symptoms and outcomes. Regarding obesity, obesity is common in these patients with pulmonary artery hypertension, but the direct role how it does this is unclear. Some fat tissue may actually protect the vessel from releasing the harmful hormones. Obese pulmonary hypertension patients may have worse quality of life, more hospitalization and longer stay. Patient with other disease, that is 30% of the pulmonary hypertension patients also have a left heart disease. So when you have a high pulmonary vascular resistance in this group, it is linked with worse outcomes. Management focuses on diuretics, heart failure medications like GLT2, MRAs. The pulmonary vasodilators are not recommended except at pulmonary hypertension centers. Pulmonary hypertension is common in COPD and ILD. Higher PVR predicts worse survival in both. Severe lung disease with PH is very poor prognosis. Some inhaled drugs help PH in lung disease, but oral PH drugs may be harmful. So what you see here is the survival graphs of patients with pulmonary hypertension who have in patients who are having interstitial lung disease, and it is showing here is that patients who are having a higher PVR, the survival rate is getting reduced. So you can stratify these patients based on the higher PVR, that is more than 5, less than 5, like that. So it can help you in prognosticating the patients. So in pulmonary hypertension due to ILD, PVR is the best single hemodynamic predictor of survival. Always check PVR in these patients because this will help you stratify them into good or bad prognosis. So we have various risk stratification tools. and like Compera, Reveal, the European Society tables, the main factors and symptoms are symptoms. NT-proBNP, 6-minute walk distance. Most patients stay intermediate risk even after dual therapy. Reduction in PVR is the key marker for improvement. Risk score predict outcome but may not be reliable trial endpoints. Regarding use of biomarkers, only BNP and NT-proBNP is validated for using in pulmonary hypertension practice. Neo tests are being developed. They show promise but are not routinely used as of now. So for novel access tool, you can use the daily step count, that is fewer than 5,500 steps per day means higher hospitalization risk. Text message reminders can help increase activity. Cardiopulmonary exercise testing using the peak use of oxygen, the VE by VCO2, they help in risk stratifying the patients. So there is a three stratum risk stratification of the pulmonary artery hypertension. The low, intermediate and high. In low risk, there is less than 5% risk of 1-year mortality. Here what you see is no clinical right heart failure. WHO functional class 1 and 2, 6-minute walk distance is 440 meters. In exercise testing, you will find the VO2 is more than 65% of the predicted, and the slope of the VE and VCO2 is less than 36. The BNP is less than 50, pro BNP is less, echo will show less cardiac involvement, and the pressures, the right atrial pressure is less than 8, cardiac index and other things are nearly normal. In intermediate, you will find a risk of around 5 to 20% 1-year mortality. Here the right heart failure is present but is occasional. The functional class is 3. The 6-minute, the walk distance comes down to 165 to 440 and the other things are reduced. In high risk, where the risk of mortality is more than 20% in 1 year, you have repeated right heart failures. The functional class is 4. You have less than 165 6-minute walk distance, and all the other parameters are affected. So use this tool at diagnosis to follow up to guide the PH therapy. The aim is to achieve and maintain low risk profile for as much longer as you can. Escalate therapy if the patient is going into any of these two fields. The guide is to recognize symptoms and the risk for the pulmonary hypertension that we have already discussed. Start with an echo, confirm with right heart catheterization, calculate the mean pulmonary artery pressure and the PVR, classify the subtype, use risk tools for prognosis, assess the comorbidity and the social barriers, reassess for the risks and therapy regularly using both clinical and activity measures. So now we look at the major new drugs that have come. The most important is the sotatercept. It is a fusion protein that blocks the activin signaling, rebalancing the abnormal growth signals in pulmonary artery hypertension. It helps shift the balance from the vessel wall cell growth towards healthier anti-proliferative signals. It acts by influencing the TGF beta and BMPR2 pathway, which regulate the pH development. The PULSAR trial added to standard therapy significantly reduced the pulmonary vascular resistance and improved the 6-minute walk distance. In the STELLAR trial, that was the phase 3, it showed further benefits in exercise capacity, heart function and reduction in the disease worsening. Side effects include telangiectasia, increased hemoglobin and low platelet, and there is some bleeding risk also. So sotatercept is likely to be included in the future standard management of all PH. The combination therapy is combining 2-3 drugs with different mechanism is now the standard for most PH as it lowers the risk of clinical worsening. Triple combination is prostacyclin, endothelin receptor antagonist and PDE5 inhibitors, which improve survival. New drugs like sotatercept may soon be routinely available to such regimen. Now, how to treat mild PH and early PH? In mild PH, still causes significant vessel damage and right ventricular changes, but these are not strong enough evidence to routinely treat these conditions with vasodilators. Early treatment may help in high-risk patients, that is systemic sclerosis, but we need more studies. Screening high-risk groups and using AI for early diagnosis and future direction is important. So in this schematic diagram, what you see is the pathophysiology and the risk of mild pulmonary artery hypertension. In histopathology, that is in panel A, what you can see is mild pulmonary hypertension shows vessel wall changes when compared to control. So this is the control, this is the mild pulmonary hypertension. You see there is increased fibrosis, which is shown here in the blue, and thickening of the vessel wall. You can see the wall vessel is thicker than the control. So the implication is structural damage starts early, even before severe pulmonary hypertension has occurred. So you can see here the vessel wall is so thick, you have fibrosis. So even though the disease is mild clinically, the pathophysiology has aggravated. So mortality risk uh, seen here with the incremental increase with pulmonary mean pulmonary artery pressure. What you can see here, this was a study which was run in a large cohort of data, which shows that there is rising at around 19. The mortality is increasing. So incremental risk is significant even for mild group of patients, that is 19 to 24, which is the mild group. There also you can see that there is a very high risk of mortality. So mild pulmonary hypertension is not as benign as we think it to be. Uh, Regarding the C, that is survival and cardiac remodeling, here you can see that there is with high mean pulmonary artery pressure and right ventricular dysfunction, you see there is a higher risk of mortality. The survival is reduced. And in the D part, you see there is reduced TAPC as the right ventricular pulmonary hypertension increases. So mild elevations are clinically significant. Early pulmonary hypertension causes fibrosis and remodeling. Monitoring these patients is very important. Now, regarding chronic thromboembolic uh, pulmonary hypertension, pulmonary endarterectomy is the gold standard and for operable chronic thromboembolic for pulmonary hypertension, but requires specialist centers. For inoperable or high risk patients, balloon pulmonary angioplasty is an option. It improves hemodynamics but requires multiple procedures and carries a procedural risk. Now BPA, that is balloon pulmonary angioplasty, is more effective than medical therapy alone but has more complications. So that must be kept in mind before you are trying to do something like this. So this is what is shown here is the balloon pulmonary angioplasty for chronic CTPH, and in this, in panel A, what you see is the before the BPA, which shows narrowed and blocked large arteries. You see the proximal blood flow is there, but the distal blood flow is reduced. It's typical of patients where surgery is required. You see noticeable improvement in the blood flow in the segments that are blocked once the procedure has been done. So in this, the distal lesions, that is the surgically inaccessible lesions, are treated. So in this, there was the proximal block. Here you have more distal block, and in this distal block you see they're gradually clearing up. You can see the blood flow is improving in the distal zones. So BPA, the balloon pulmonary angioplasty used in managing this condition is important. Serial sessions are needed and you can get good outcomes, as you can see here. Physical activity and rehabilitation is a very important part of this. Exercise training programs are safe and improve exercise capacity, quality of life, and the heart function. Physical activity needs to be encouraged. Clinical trial and innovation trials now include adaptive and pragmatic design using flexible inclusion criteria and real world population for more generalizable results. New endpoints like moving beyond the 6-minute walk test to use actigraphy, risk scores, and patient reported outcomes are more being utilized. Data harmonization, rapid approvals, publishing negative results are encouraged to speed up the progress of the disease and the trial. So for future direction, precision medicine is something which we need to go in, because this is a rare disease and we need to be more focused on treating the case. Tailoring therapy to individual patient subtypes and risk profile is growing focus. Continued research into novel drugs, better use of existing therapies, and inclusion of underrepresented groups will drive better outcomes in these high risk groups. So this is the treatment algorithm that you can use. The step 1 is reactivity testing. Do this in all patients with idiopathic, hereditary, or drug inducible PH. The vasoreactive positive test, that is, if the test is positive, then start a calcium channel blocker. For non-vasoreactive or connective tissue disease related PH, risk stratify the patient into low risk, intermediate risk and high risk. For low risk, start dual oral therapy, that is ERA with PDE5, that is ambisatran with sildenafil or tadalafil. For intermediate risk, also start dual oral therapy. And for high risk, start the dual oral therapy plus include a parenteral prostacyclin, that is use it IV or subcutaneous. Incidental PH with cardiopulmonary comorbidities, in those cases start with oral monotherapy, that is you can go for sildenafil or tadalafil or the ambisatran. The risk stratification is not validated in this group, so do not use it. So the key point is note that the dual therapy needs to be given. Add prostacyclin IV or subcutaneous if it is high risk. Now, how to do this precision medicine research oriented assessment? Here what you do is you first risk stratify and screen all patients. This is the step 1. Then select only the intermediate risk and the high risk patients for the trial. This enriches the trial. Then you give 2 therapies, a new treatment or a placebo. Now increased chance of showing a treatment effect because most high risk patients are included over here. The next is adaptive enrichment. Here you randomize all patients and you use a biomarker to risk stratify them. Enrich the trial and continue only with patients who continue to show benefit with the drug, and you do more interim analysis and then try to enrich and find out which type of drug is being giving better results. So there is gradual enrichment during the trial because of more interim analysis. The next step is randomized discontinuation design. All patients start on active treatment, that which is open label, and gradually when you see improvement you continue the treatment. In stable patients you randomize them, and for worsening patients you just remove them. So this helps again in enriching the trial and removing those patients who will dilute your result. So these are the recent advances as we have discussed. The sotatercept for advanced PH, combination therapy for moderate to severe PH, early therapy, try to find and give therapy and do not neglect them. For CTPH, go for angioplasty. Exercise testing and rehab is a major design, and future we need to do better trial designs. So to summarize, this is the whole pathway for the pulmonary hypertension. So there is something called the classical treatment, and these are the new treatment modalities. The classical treatment is the prostacyclins, the endothelin antagonists, and the PDE5 inhibitors. We know their mechanism of actions, which is vasodilatation and decreasing the proliferation. These are the new targets that we are looking for, as we have discussed the various genetic part which will be there. So the most common one that is currently being available is the sotatercept. The others are still in the developmental phases. So you can go through the presentation again to find out which type of pathway is being targeted by which drug. Thank you for your patience.